Thank you for joining us for today's webinar. Welcome to this expert webinar series on endometriosis. This is a series presented by the Canadian Association of, Canadian Society of Abdominal Radiology. It is the first of a two-part series that we're planning. I would like to begin by acknowledging the Indigenous peoples of the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improve our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. My name is Basma Lernout. I'm a breast and body radiologist and an assistant professor in the Department of Medical Imaging at McMaster University. I had the privilege of chairing the CAR Endometriosis Working Group, and I also sit on the CSAR Executive Committee. I am honored to be the moderator of this webinar today. This webinar is an accredited group learning activity, Section 1, as defined by the Maintenance of Certification Program by the Royal College of Physicians and Surgeons of Canada, and it is approved by the Canadian Association of Radiologists. Participants are eligible to claim a maximum of 1 hour. Your certificates of attendance will be available after completing the webinar evaluation. Before I begin, I wanted to make a few housekeeping comments. We will be saving all the questions until both speakers have presented. Please use the Q&A features to enter your questions. The webinar will be recorded and available on the CAR website. Today, we will be learning about advanced pelvic imaging for endometriosis. We are very fortunate to have two renowned speakers, both of whom sat with us on the endometriosis working group and were incremental in it. We have Dr. Priscila Crivellaro, who is a breast and body radiologist and assistant professor at Western University. And we have Dr. Mathew Leonardi, who really needs no introduction, and is an advanced gynecological surgeon and sonologist at McMaster University Medical Center. Dr. Crivellaro will be speaking first, and the title of her presentation is Advanced Imaging for Endometriosis, Challenges and Gaps in Practice. Dr. Leonardi will then follow, and the title of his presentation is Advanced Ultrasound for Endometriosis from Pattern Recognition to Practice Integration. And we'll start with Dr. Crivellaro's presentation. Priscila, the floor is yours. Please share your presentation, your screen.
I'm gonna share my screen. Can you see my screen? I'm gonna just move this from here.
Yes, we can.
Perfect. So, welcome everyone. It's a pleasure to be here. Thank you, Basma, CAR and CSAR for the invitation. And I'm going to be presenting to you the main findings of our national survey on imaging practices for endometriosis, where we aim kind of to shed a light on the current patterns, challenges, and educational needs in this important matter. Let me see. I have no disclosures for this presentation. And just a little bit of a background. Endometriosis is a prevalent condition with significant morbidity. It affects approximately 10% of women at the reproductive age, and it's basically a chronic inflammatory disease defined as the presence of endometrial tissue outside the uterus. I won't go very deep in the physiologic changes, but we know that the main symptoms are basically chronic pelvic pain, dysmenorrhea, infertility. And if you are a body imager, if you work with women with women's care, you're going to see these symptoms every day, more than once, probably. And most of these patients, they have very similar clinical histories. They come and they say many times the same history. I went to many physicians, I went to many doctors, I did many studies, and they never found what was the cause of my symptoms. I had more than one surgical procedure and my symptoms are still there. So you don't have to be a doctor. If you talk to your friends or they always have similar histories. And that's how debilitating is, because if you live with a chronic condition and you can't find a solution, that can cause you to many issues, including mental issues. There is more chance of depression, anxiety, and even to do your basic day-to-day tasks is more difficult if you are dealing with chronic pain. So we do have imaging, advanced imaging that's available for the evaluation of this disease, terms by ultrasound and MRI, and we know already that the imaging plays an essential role in diagnostic and managing these patients, especially for those patients who have deep endometriosis. So advanced pelvic ultrasound and also MRI, they are used to confirm, but also to follow patients with the diagnosis of endometriosis, and especially for pre-surgical planning. Accurate imaging can reduce unnecessary surgeries, and there is already data enough to prove that there is better outcomes when we have imaging previous to the surgery, because endometriosis is a very complex disease that involves many pelvic organs and pelvic compartments. It's not just a uterus and ovary disease, right? It can involve the bladder, the rectum, go even beyond the pelvis. So we do have to know what we are dealing with before we go for surgery, ideally. And because it's so complex disease, the imaging evaluation must be performed for a professional that was trained, either radiologist or gynecologist and sonologist in the case of the ultrasound. So you do have to have training to identify the findings. They might be very subtle on MRI or ultrasound. And despite of this clinical significance, despite of the importance of this disease, we knew that utilization of these imaging modalities, it was very inconsistent throughout Canada. So the CAR endometriosis working group was basically a group of 10 radiologists and 1 gynecological surgeon that were with us today, and dedicated training in endometriosis. Our main tasks were basically try to understand the full scenario, to try to provide guidance and benchmarks to ensure quality of the technique interpretation for those advanced modalities to improve the diagnosis of endometriosis in Canada. So we decided then to develop how we could assess that, right? How do we want to determine what's the main issues and the main points? So we decided to develop an anonymous survey to further understand the full panorama of diagnosing endometriosis in Canada. So basically, we asked about availability of these studies, the specialist comfort in reading these studies, what were the challenges that they faced by performing these studies, the protocols that they use, how standardized those protocols they were, issues with reporting studies, also quality assurance programs, and also their interest in more teaching, or how do they feel about the quality of the educational material available. The methodology of our survey basically was designed to capture a broad spectrum of information. So we wanted to ensure a holistic view of current practices and also perceptions of the members. It was an anonymous 36-question survey. It was distributed through the CAR platforms in English and French. It was available for 37 days. And we included several multiple choices, Likert scale, and also open-ended questions. We included, again, training, current practices, protocol, quality improvement, and continuing professional development. But unfortunately, our response was 89 radiologists. So 5%, the response rate was approximately 5%, which is lower than other radiology questionnaires. And we can come back to that a little bit in a moment. So understanding the demographics help us to contextualize the findings, especially considering the variability of resources and training opportunities that we have across regions, right? So the majority of the respondents, they were early career, primarily from the community radiologists, and most of the answers came from Ontario and Quebec. And so more than 33%, they were in the first 5 years of practice. And And when we asked them about the utilization of advanced pelvic ultrasound, especially, we could see a very low adoption. Basically, 38% only of the respondents, they had ultrasound at their institution. And in between those 38%, you can see here that 19% of those, they were not reading the studies. Most of the ones that were reading these studies, they had less than 5 years of experience. They performed less than five exams a week. And their training was primarily received during residency or fellowship. So this kind of low utilization and limited experience highlights a gap in both practice and training, suggesting that we need to enhance educational resources for those interested in performing. So most of the studies were performed by the radiologists, and also this ended up being one of the challenges of implementing advanced imaging with ultrasound. When we went to MRI practice, we do have the MRI interpretation was more common, but again, it came from a limited experience, and also they were, again, majority within their initial years of practice, training during residency or fellowship. And there was a very heterogeneous use of the MRI protocol. So although many of them, the responses they use contrast study, the number of post-contrast series varied a lot. The scanner where the studies were done, and again, very few studies per week. And we know that if you don't have enough exposition to a pathology, that can imply on you not having enough knowledge or not keeping your skills to read those studies. So, and we even ask about extrapelvic endometriosis, because we know that the endometriosis goes beyond pelvic imaging, right? So for those most common studies requested were soft tissue for evaluation of the abdominal wall, MRI, or diaphragmatic thoracic CT. But many of those radiologists, they didn't read those studies. And referring source was usually, of course, the gynecologist accounted for most of the requests. So when we went to the quality assurance and workflow gaps, we could see that something that is very interesting is that when we are in academic center, it's a little bit more, it's a little bit easier to have this, but multidisciplinary rounds were available only 10% of those that performed those studies. Use of template reporting was in approximately 12%. 17% developed their own templates, and audits or any form of Q&A, there was present only in 23% of those who had those studies at their institution. And the biggest challenge was timely scheduling. And you have to understand that when we don't have, one of the main issues when we are doing studies, of course, we do have to have the necessity of the study as important, but also the support from the department, the multidisciplinary rounds, everything kind of, if you have feedback about your work, and how you're improving, is much easier for you to see how much difference you make in patients' life. And when you think about scheduling, that was also one of the biggest challenges. We know that we do have time constraints for MRI, ultrasound, and that's an issue that is very difficult and complicated to address. So if you look at I won't go over this entire table, don't get worried, but the main challenges referred for those that were performed the studies was the lack of standardized protocols, the limited access to specialized training, inconsistent reporting practices, and time constraint and scheduling. So most of these challenges, they could be addressed with multidisciplinary collaboration rounds, and also more clear guidelines from the societies. That was what we were trying to understand. The time constraint is scheduling. Basically, we know that if you do an ultrasound for a pelvic ultrasound, it's going to take us 20 minutes, but maybe if you want to do for endometriosis, it's going to take you 40 minutes or more. So in a schedule that is already very tight, it's very difficult to understand how we can fit that in our day-to-day life, right? Regarding the educational needs, most of the participants, they showed a desire for structured training programs in advanced pelvic imaging and endometriosis. Also, regarding development of standardized reporting templates, web-based workshops and continuing medical education, and especially integration of the multidisciplinary case discussion. Because again, this discussion and having feedback about your cases and work, that's essential. So we know that the response rate was very low, and we believe that this might reflect the fact that despite endometriosis is such an important disease that affects the quality of life of many patients, there is still a lack of understanding of how much the studies can benefit the patient. And even though we had this kind of few respondents, most of them, they were not performing dedicated study for endometriosis. And not having professionals performing these studies limits also the transfer of knowledge. So we don't have anybody to teach the new RADs or the new sonographers or the new gynecologists to be doing those studies in the future, right? So, and this results in many places still having patients undergoing surgery without prior imaging. So the conclusion of our paper is basically we have a significant variability in imaging practices for endometriosis in Canada. There was a clear need for standardized protocols and enhanced training. And we do need to make a collaborative effort to advance the role of imaging endometriosis. The respondents were basically asking for education, support, and standardization to help them meet clinical demands and be able to improve patients' care. So the main recommendations of our papers was basically establish national guidelines for imaging endometriosis, implement standardized training modules during residency and fellowships and even after training, promote multidisciplinary teams involving radiologists, gynecologists, and surgeons, and also encourage research to show even more from what we already have, how important and impacting these studies can be on patients' outcomes. So my knowledge for the Canadian Association of Radiology, the working group that made this possible, the survey, for those who answered the survey, because we know that most of us, we don't really have time to answer many surveys nowadays, and also collaborating institutions that was made us able to develop the additional guidelines. And that's the QR code for the paper. And I'm happy to take any questions by the end.
Thank you so much, Priscila. Thank you for making such a long paper very simple and easy to understand. We will be holding the questions till the end, and I would like to kindly ask Mathew to share his screen. Mathew, the floor is yours.
Hello, everyone. I'm going to stay off camera. I'm so sorry. I have very red eyes from allergies, I believe, I hope. And so I'll spare you all that. Welcome to the very large audience, and hello to some of the familiar names and to the unfamiliar names. I really hope that this will help solidify the very nice presentation by Priscila on the study that we did and touching upon the elements of importance. To be honest, I cannot tell you strongly enough how this changes patients' lives. Ultrasound evaluation for complex gynecologic problems such as adenomyosis is a game changer. It validates them. It gives them an understanding of what's going on in their body. It provides them an ability to choose treatment options. And then from a selfish perspective, gynecologists' practice can be revolutionized by knowing what they're helping their patients with. Surgeries are not abandoned or incomplete. It really is game changing. So I really appreciate the large audience today, and hopefully there's a lot of enthusiasm for the adoption. As you could tell from the survey, pretty much across Canada, we are at the infancy of this. And I think that's true for probably still most of the world. Just obviously because we're doing virtual, if there are any issues with the presentation, you can't see the slides, you're seeing my notes version, please, Basma, speak up.
We can see your slides good, don't worry.
Perfect, thank you. And thank you again for the invitation to you and to the Canadian Association of Radiologists. Here are my disclosures. And the outline is very simple here. It's going to be focused on the endometriosis task force effort of publishing the ultrasound practice statement. And then as well, I'm going to focus on really high yield concepts, showing you lots of ultrasound footage, videos, and using that guideline as a roadmap as to how we can implement endometriosis ultrasound in our communities. So for those of you that have not yet seen this guideline, this is now published a couple years ago, and I'm just very proud and honored to have been part of this working group led by Basma and a number of other individuals at the Canadian Association of Radiologists. This should be a staple article for you, hence the QR code there. At the end of the article, there's supplementary material as well, which is really fundamental, and that's where our template for reporting exists, as well as a template for some clinical information that you can acquire from your patients in a very easy and concise fashion. And I can tell you that this is what I'm using day to day. And so it is with my a stamp of approval from an endometriosis surgeon sonologist lens. And so please do save this article in your armamentarium for future utilization. And also to inform you, and if interested, you're welcome to take this QR code as well. The Society of Obstetricians and Gynecologists of Canada, very much simultaneous to the working group at CAR, has published a guideline. And for the first time ever, the Canadian group has divided the guideline into a diagnosis and impact section, and the management section is coming up soon. The working group is actively finalizing that guideline. And this just goes to show that since the 2010 guideline published on endometriosis, we have reached completely new levels where we have an entire guideline focusing on diagnosis, very heavily so on imaging, but also on the intricacies of diagnosis as it pertains to the clinical history, as it pertains to surgical nuance, and as well histology. So each of the various diagnostic tests that are applied to our endometriosis patients are focused on in this article. This will also tell you, the radiologists in the room here, that across the country, the demand for endometriosis imaging is only going to continue to grow because it is now within our published guideline. So back to the CAR practice statement on advanced pelvic ultrasound. The first point that we made, and this was discussed already by Priscila, this is very common. Up to 10% of our patient population walking around the world, endometriosis is one of the most common diseases. And we can indeed diagnose and map the disease using ultrasound, but we cannot currently rule out endometriosis on any imaging modality. And that's in particular true for superficial endometriosis, the most mild subtype of the disease. Therefore, patients should never be invalidated or dismissed based on normal imaging findings. And that's why, as part of this guideline, as well as the SOGC guideline, we have given people some tools, including the utilization of this statement. It is important to remember that a normal ultrasound does not mean the patient is normal. It simply means we have not identified endometriosis or other pelvic pain generating pathology on today's ultrasound. At this time, we cannot rule out endometriosis on imaging tests. If there is a high clinical suspicion in the setting of normal imaging, referral on to gynecology or additional diagnostic strategies can be considered. I don't usually read my slides, but this I read because I cannot tell you how many patients I see who have been told by their primary care provider, by their gynecologist, your imaging is normal. That means you are normal. That means what you are experiencing is not real. And it is so far beyond what we expect of the interpretation of our reports when we're providing those reports. But I can't say strongly enough that the people who are interpreting our reports don't always have the understanding of what the utility is. And that's also demonstrated in the numerous reports where we receive the requisition saying, rule out endometriosis. Obviously, we cannot do that, but people still want us to do that. So I really encourage you to make these types of statements at the conclusion of your imaging reports when it is a normal scan. The second key point from our practice statement, that there are criteria to differentiate basic from advanced ultrasound, and advanced comprehensive ultrasound is required for the assessment of endometriosis. Now, I will remind you what a basic ultrasound generally looks at, the uterus and the ovaries. And this is what many reports from an endometriosis patient might look like. This is really one of the main reasons why I have pursued becoming an imaging expert. I saw report after report after report saying there is a uterus, ovaries are present, and this is not helpful for anybody. So detail is required, and this is what it should look like as it pertains to endometriosis and anybody with pelvic pain. So of course we look at the uterus and we look at the ovaries. And though this particular presentation can't focus on this, the uterus assessment should be as guided by the Morphologic Uterine Sonographic Assessment Group, as well as the International Federation of Gynecology and Obstetrics for things such as adenomyosis and fibroids. Ovaries we should be looking at with the lens of the International Ovarian Tumor Analysis Group and or ORADS. We look at the mobility of the uterus and we look at the mobility of the ovaries through dynamic mobility assessments, sliding sign, and ovarian mobility. Now, for endometriosis, we especially have to look at structures such as the bowel, the uterus sacral ligaments, the bladder, but now we're getting even more into assessing the perimetrium, for example, for deep endometriosis involving the ureters and the nerves. We're also looking at the peritoneum, which is the entire covering of the pelvic cavity for superficial endometriosis. Now, I've referenced MUSA, IOTA, and FIGO. Endometriosis is guided by IDEA, the International Deep Endometriosis Analysis Group. And this original paper from 2016, now nearly 10 years old, guides us through a 4-step process. And that's another article that you should have in your toolbox. And there are addendums coming forward from the IDEA group on things such as perimetrial endometriosis, superficial endometriosis. These are things that we can reliably assess. Now, at the end of the list of the on the left, you'll see tenderness. Now, tenderness is something that the IDEA group does recommend. This is to help understand whether somebody may have tenderness associated to endometriosis. But what many have not fully recognized is that tenderness may not just be a marker of endometriosis. It may also be a marker of other pain generators, such as myofascial pain. And so even though this is not quite a sonographic finding, it's something that's still very important to report when you're doing endometriosis ultrasound. The next point from the practice statement was that we should be adopting reporting templates that enable systematic and reproducible communication between healthcare providers. And so first and foremost, we do recommend the background information. And as you can see, we provide in Appendix 2 a clinical intake form, which can be digitized and hopefully used in a smart form for a lot of reporting softwares. And we do encourage a small amount of clinical history, which allows for that clinical context. And in my world as a gynecologist, I'm very familiar asking these. But I can tell you now I've trained many sonographers who can collect a number of pieces of information from this, and they do it in a way that is not necessarily bi-directional, where they're answering patients' questions, but they're collecting information for the purposes of enhancing their ultrasound performance, interpretation, and ultimately the worksheet that they put together for us. And I've taken just a sample report here. This is the first section involving the uterus and the ovaries. You can see here we're looking at FIGO when adenomyosis is characterized. We use MUSA. When IOTA is implemented, we use features from them to characterize, for example, hemorrhagic cysts. And then with respect to deep endometriosis, we're dividing this into the anterior and posterior compartment, and then dynamic maneuvers such as the sliding sign and the triangle sign with an interpretation that has a summary of the various aspects identified. Now, in the context of me performing these ultrasounds, a sonologist-led ultrasound, I do provide feedback in real time to patients, but of course that's going to need to be customized based on the setting. This does not happen when we're doing regular gynecologic or endometriosis ultrasound performed by the sonographers. And in those cases, the patients don't get in real-time feedback. But that's just a glimpse of what it can look like. And the supplemental material in the practice statement is guided by my day-to-day practice in terms of the practicality and the relevance for a surgical gynecologist audience. Point number 4 is that the posterior compartment is the most important site of endometriosis, most common site. This is where the focus should be, the most value. So if you're going to be implementing any endometriosis imaging, this is where to start that education. And so in that article, we lay out what is within the posterior compartment, as well what is in the middle and the anterior compartment. And so you can see we have the vagina, the torus uterinus, which, as all of you know, is the retrocervix, where the uterosacral ligaments attach to the uterus. Those are the most important structures because they are technically the most common. The bowel, including the rectum, rectosigmoid, and sigmoid, are really impactful from a surgical decision-making perspective. Even though it's not as common as uterosacral ligament endo, it is still very common. And then you'll have the peritoneum of the rectuterine pouch, which is between the uterosacral ligaments, above the peritoneal reflection. And so that's the main structure to focus on, list of structures to focus on. So now, with my time remaining, I'm going to take you through how to do some of this in a really high yield fashion. And I try as best as possible to, in particular, use surgical footage for the imaging audience, the sonographers and the radiologists, because it really, I think, solidifies how this disease can look to us in a different way. So here we have the sigmoid colon, and I'll point you to this particular area where I say what is under the surface. You see there's a little blue area here, a little bit of red. Maybe these epiploica look like they're kind of stuck to each other. Overall, not particularly concerning in appearance. But below the surface, we have a very classic sigmoid deep endometriosis nodule within the muscularis layer of the rectum. That's the normal muscularis layer to the top right. And here we have that very thickened hypoechoic muscularis layer. This lesion is nearly 4 centimeters in its length. So we committed to doing an anterior resection for this patient. And as you can see, when we start to peel those epiploica off of the rectum, that endometriosis visually to us grossly is revealed. We knew it was there. And when we cut that lesion in half, it looks almost exactly like the ultrasound image as well. It's got that retractile nature within the muscularis layer. So as per idea, the bowel is separated into the lower rectum, which is truly the fully retroperitoneal rectum, followed by the upper rectum. It's starred because it is the most common location for bowel endometriosis. And this is above the peritoneal reflection. 3 is the rectosigmoid junction, roughly at the level of the uterine fundus. And 4 is the sigmoid, which is pretty rare, but nonetheless still possible. As per idea, all endometriosis lesions should be measured in 3 orthogonal planes: length, depth, and width in the transverse plane. And you can see here that example from the idea consensus statement. Now, if we look at the normal bowel here, we can see that we have the serosa, which is the white line overlying the muscularis layer, consisting of the outer longitudinal and the inner circular muscle. And then we have this white line, which is not something that is actually reported by the idea group, but something that I've been paying a lot of attention to because it can tell us the depth of infiltration of the bowel lesion when, in particular, the inner circular layer is preserved. And that has a lot of surgical relevance for us, followed by the mucosa and the lumen. And you can see here there's some fluid in the pouch, which is always your friend and very helpful to more clearly see the structures of the posterior compartment. Now, I'll remind you, at surgery, this is all we see as surgeons in normal cases. All we can see is the serosa. We cannot see through anything with our eyes at surgery, so the imaging is essential. And so here we have a very classic lesion. You can see that in relativity to the posterior muscularis, which is very, very, very rare for endometriosis to evaluate, we have a very focal area of thickening, and that's in the longitudinal plane there. And we're placing our calipers, resulting in roughly a measurement of 2.5 centimeters. And then in our transverse plane, about 16 millimeters. You can, if very C-shaped, measure this with the trace or the spline function, but it's not generally going to make a huge difference from surgical planning standpoint. And so the steps to find bowel endometriosis is to first find the bowel at the at the anal verge, and you're looking at the lower rectal muscularis here. And then once you find that, you simply follow the black line. I'll show you a video in the next slide on that following of the black line. And it's a side-to-side motion. You really want the probe to stay in the posterior vaginal fornix, which is actually quite unusual for our scanning techniques compared to most traditional gynecologic ultrasound. And so this positioning of the probe in the PVF is one of the things that's the highest yield for teaching sonographers, radiologists, and sonologists. And then finally, with respect to the bowel, it's really important you follow it as high up as possible, but you can get lost. So sometimes restarting can help, or getting a global perspective by pulling the probe back out into the anterior fornix and just getting a sort of a lay of the land appearance of where things are. Sometimes I find the bowel at the level of the uterine fundus, above the fundus, the sigmoid, and I actually then follow it back down in the direction of the anal verge. And sometimes that's actually an easier pathway to find. So here we have a clip that is aiming to show you the following of this black line. And the vagina is a perfect avenue for us to evaluate the bowel because it's literally millimeters away. And so we can slow and steady follow this black line, and you can follow it up as high in the body as possible. This is a totally normal case, but as soon as you follow it and you find a bowel nodule, they jump out at you. In the vast majority of cases of bowel endometriosis on ultrasound, it's actually very easy to find. So that's the bowel. We'll move on to the uterosacral ligaments, which are, again, the most common location of deep endometriosis. Surgically, here on the right side, we have a deep nodule, and on the left, we have superficial endometriosis. This corresponds to the nodule on the right uterosacral ligament. You see it shares the same features as bowel endometriosis, which is hypoechoic nodule, quite homogeneous overall. And so when we are trying to find the uterosacral ligaments, we have to be in that posterior vaginal fornix, and we lateralize the probe to accentuate this white thick line from the center where that line is very thin. Now that's going back to the, we'll go back to the beginning of this clip where we see the very thin white line in the center of the pelvis. This is the peritoneum overlying the pouch, overlying the vagina, and this is the uterosacral ligament here. So this is what a normal uterosacral ligament looks like. And here we have another normal uterosacral ligament, and this is actually slightly enhanced with the presence of fluid. Very homogeneous, hyperechoic. Here's again at surgery. This is the exact case, just to give you a reminder of what that looks like. And so when you see these uterosacral ligaments, surgically, you can appreciate that they're oblique. They're not straight up and down. They're sort of diagonally shaped, which means the probe needs a degree of rotation. And so on the next slide here, I'm going to show you, this is a view from the vulva perspective. So there we go. We're going to see how we position the probe. So essentially we start in the midline and we're moving the probe to the patient's right leg to visualize the left uterosacral ligament. And the probe is being rotated slightly medially to accentuate the longitudinal nature of that uterosacral ligament. In order to find the other side, you simply do the opposite. You move the probe to the patient's left leg, which then allows you to angle the tip of the probe to the right uterosacral ligament. And you see there is a very slight rotation of the probe towards the medial aspect. The notch on the probe rotates medially. Usually you don't need to rotate very much. Most of the time I'm about 10, 15 degrees of rotation to get that full longitudinal appearance. And so what does uterosacral ligament endometriosis look like? We've seen one picture of it already. We have different variations. Sometimes they're in association to endometriomas. And again, they have this hypoechoic nodular appearance. In this case, it's completely adherent to the uterosacral ligament and endometrioma. Same in this particular case here. We have a classic ground glass endometrioma, and here we have uterosacral ligament endometriosis, very classic low-level echo nodular appearance stuck with the utilization of the dynamic pressure. You can look at these nodules from the anterior fornix through the cervix, but they're very vague, difficult to appreciate. In this case, we had bilateral endometrioma stuck to the uterosacral ligament nodule, which traversed the midline via the torus uterinus. And I'll show you what it looks like when you actually put the probe in the posterior fornix. It's actually, in my opinion, much easier to see because it's much closer to the probe. So we're actually going from left to right, and we can follow this hypoechoic nodule. It doesn't leave our sight the entire video clip here. It's present the whole time. And so this is what we call a horseshoe nodule that traverses from one uterosacral ligament to the other via the torus uterinus in the midline. And it just so happens in this case, both ovaries are pulled in and under in the direction of those uterosacral ligaments where they're densely adherent. Now, even though this is the hardest form of endometriosis to find, I needed to talk about it for a few minutes because it is actually the most common form of endometriosis. And the only way that we'll really get to the maximum capacity of imaging is if we do routinely evaluate for superficial endometriosis as well. Now you're saying, you're thinking, how are we going to find these lesions? They're barely above the surface of the peritoneum. They're 5 millimeters, or they're less than 0.5 millimeters, excuse me. They're tiny lesions, but they are possible to see. And I'll show you in this particular case how subtle it can be, but also how obvious it can be. This is the peritoneum overlying the back of the vagina, and this lesion here is abnormal. The peritoneum is like our skin. It should be flat unless somebody has had surgery, an inflammatory source such as appendicitis, pelvic inflammatory disease. This peritoneum should be crisp and clean. This is not. Here we have a hyperechoic focus with a jiggle test positive. It's literally moving in the fluid. This is endometriosis. Superficial endometriosis can also look like irregularities within the peritoneum, where we have hypoechoic breaks in this line here. In some instances, we have even cystic lesions, and this is on the peritoneum. Again, we're at the back of the vagina here. This is the peritoneum in that central aspect of the pelvis. And with the application of pressure, you see the jiggling of this cystic lesion growing off of the peritoneum. Sometimes we have cystic lesions that are more within the peritoneum rather than immediately coming off, but you can definitely see this breaks that surface as well, followed by a hyperechoic focus just on that peritoneum there. In this particular case, we have a multiple hyperechoic foci and a hypoechoic irregularity between the two. All of these are superficial endometriosis. Now, I'm not suggesting that by any means tomorrow anybody is going to go off, but once you start to look, once you start to do endometriosis ultrasound, in many cases, these actually do start to jump out at you. And once you start to systematically assess them, it is possible to be accurate in your assessment of them. And the final portion of this talk before we end is the sliding sign. I think that the sliding sign is the first thing that many centers around the country have considered introducing, and maybe rightfully so, because this has one of the most impactful decision-making experiences for patients and their gynecologists in the clinical setting when surgery is being planned. So we have the sliding sign, which is applicable in both an anteverted and a retroverted uterus. And we look at the adhesion state behind the retrocervix and along the posterior uterine serosa. In this particular case, which I realized the idea group kind of created an anteverted retroflex uterus. Essentially here, the utility of the idea sliding sign is at the fundus, but there is another area back here, which I'll share with you in a moment. So that sliding sign really does require a very intent, a lot of intent when you're performing it. One of the things that we're seeing a lot of is the introduction of this where it's not being performed with enough strength per se, not enough ballottement, not enough pressure, and we're getting a lot of false positives on a negative sliding sign, meaning an obliterated pouch. This is with the ballottement technique where we apply pressure with our non-scanning hand above the pubic bone to push that uterus down. And we see that it slides very effectively. When it doesn't slide, that's a negative sliding sign. This is something that I have full talks on to be able to teach this, but in the context of this, really just informing you that the technique is so key. If you introduce it without a strong technique, you will not get the diagnosis right. Now, the triangle sign is the addition to the retroverted uterus because this area behind the uterus, you can have a major site of adhesion between the vagina and the back of the uterus. And I'll show you what we mean by this triangle sign. So with the application and release of pressure here in this retroverted uterus scenario, you can appreciate that the uterus falls off the back of the vagina, which is where the peritoneum is. This is what we call the present triangle sign, positive triangle sign. This indicates a non-obliterated pouch in the patient who has a retroverted uterus. Now, the negative triangle sign is seen here. With the release of pressure, we see no filling of fluid, even though there is some fluid in the pouch here. In addition to that lack of movement, that lack of a triangle, i.e. a negative triangle sign, we see that the traditional sliding sign when applying pressure to the level of the fundus is actually sliding relative to the bowel. So this may have been historically a false negative, whereby we said that things were sliding, but actually it's not sliding. And this patient could have surgery where the impact would be either abandoned or an incomplete surgery. And for the astute eyes here in the audience, or soon to be astute eyes, the more you learn about endometriosis, you can actually appreciate that the reason this triangle sign is negative is that there's deep endometriosis in this space between the uterine serosa and the back of the vagina. Even though I didn't talk about endometriomas and they're so important, the main thing I wanted to tell you about endometriomas is that they almost never exist alone. These usually are in the context of stage 3, stage 4 endometriosis with adhesions, often involving the bowel, often involving bowel endometriosis. These really do require advanced surgical training if somebody is going to be operating on them. There's no logic in a patient undergoing an ovarian cystectomy if they have an endometrioma. The logic should be they're undergoing excision of endometriosis, including a cystectomy if an endometrioma is present. And so if you are telling your gynecologists in your communities that there's an endometrioma and they're planning a cystectomy, I can almost guarantee you that they are going to be leaving behind residual endometriosis. Now, my very last message for you as I close is this. It is not so easy to do endometriosis ultrasound. It is possible to learn. There are learning curve studies that have shown that it is possible to learn within a reasonable amount of scans. Generally, less than 50 is thought to be the foundation. And I have taught many people how to do endometriosis scans very effectively. But introducing it into practice in a Canadian landscape may be challenging. So myself and a sonographer from Australia, where the system is actually quite similar to our Canadian, we proposed a simplified protocol for the initial assessment of endometriosis. This is less complex than the IDEA approach, involves slightly less structures, shorter duration of time. We believe this to be much more high yield. Here we have the differences between the various types of scans. The routine pelvic ultrasound, you can see uterus, ovaries. The simplified scan has a few additional really high yield structures. And the advanced ultrasound, really the comprehensive ultrasound, which anybody who's pursuing surgery should undergo. That is where we have allocated all of the various structures to assess. I really do appreciate your time and the opportunity to talk with you all today about this really important subject. I do a lot of education online, YouTube, posting lots of lectures. If you want more knowledge, please don't hesitate to check that out or reach out to me via my email address there.